Great. So it's really a pleasure to be here, and I was so honored. And the video kind of tells the story, but I'll do anything for NCCS, and so it's great to be with you here today. And it's also, often in my career, I was the last one on the program. I was, doing quality of life research, and everybody thought, oh, yes, that's good, let's put it on the program, but I was always end. Well, here at this audience, I know I'm front and center, so it's great to be with you. So I'm going to just turn around a little bit so I can see my slides. So Shelley asked me to kind of refresh this talk, and it turned out it was in 2014, so that's how long ago it was. And I have to say, there's a little sadness in that because not much has changed since 2014, and that talk was at, I think, the first palliative care meeting that ASCO had. So they have actually a separate small meeting on that. And so my task was to talk about palliative care and survivorship care. And it was also shortly after the 2013 Institute of Medicine report that I chaired, which was very much pushed by Ellen Stovall. Ellen had been very instrumental and was the co-chair of the original Lost in Transition Survivorship report in 2005, 2006, where treatment summaries were made a recommendation and care plans. But her real dream actually had been to have care planning right from the very beginning. And in the 2013 report from the IOM, which I chaired, which was about a cancer system in crisis, we really were able to then put care planning, treatment planning from the very beginning in there, and kind of had the bookends for this. But I think we're still very challenged. Much of this has not happened. But palliative care was put into that report, and I think there's been some movement in that, and I don't want to be all pessimistic about it, but I want to tell you why palliative care is integral to survivorship care. So just a little bit about me and why palliative care is of interest to me. So I finished my hematology oncology training in 1978, which was a long time ago, and I was invited to take a faculty position at an affiliated VA with UCLA, and the chief of medicine said, oh, by the way, we have this intermediate care ward, and down the street at the other VA, they were doing a hospice demonstration project. And he said, would you like to develop this intermediate care ward and, develop a hospice here? And it was really an opportunity for me to think about how one would want to do this, and I very quickly appreciated with the veterans that I was taking care of who all had advanced prostate, colon, lung, which we couldn't treat much in 1978, that really trying to give palliative care from the time of diagnosis, even though it may not be a long life, was very important, and not just waiting till the last few weeks of life. So I actually was able to do that, and it was a wonderful experience. But you can see what was going on at the time. There was a lot going on in terms of the development of hospice care. It took us a long time to get the Medicare benefit for hospice. It took many years after that for that even legislation to pass. And so I developed that ward, and I met Fitzmullen actually at I think it was a drug company activity that was focused on quality of life. He and I were on a committee together. He had come out with his 1985 article on seasons of survival in the New England Journal, which really put survivorship on the map as an issue for patients who were cured now or living longer after cancer, and then was invited to go to Albuquerque. And that was really an important point, because at the time, I was identifying the work that I was doing, which was primarily research or this palliative care ward, as cancer rehabilitation, because that was the only thing that was out, that was a label for the kinds of things, taking care of the physical and emotional activities that would go on after cancer. And being at a VA, we had a very good physiatrist. I was able to run this wonderful ward, and it was a terrific opportunity. But then being part of the birth of NCCS gave me a new name for what I was going to be doing, and that was cancer survivorship. So that really was kind of a turning point in really thinking about life after cancer. And it starts at the time of diagnosis, as I'll show you, and that we really need to think of that, whoever we're treating from the very beginning, and how we need to incorporate palliative care. So I rose to the ranks of being chief of hematology oncology out there, but then kind of I had a midlife crisis, and I said, it's great that I can teach and I can take care of patients, but I really want to do more. And there was an opportunity for me to take a job back at UCLA at the main campus in the School of Public Health and Health Policy and Management, and then ultimately in the Cancer Center to lead where I've been for 30 years as the Associate Director for Population Science Research. So it's just been a wonderful career that I've had, and again, doing this now for the last 35 years under the umbrella of survivorship. So just a few remarks about Ellen, who some of you knew, but others didn't. She was really an extraordinary human being. As I said last night, we had many activities that we did together, and so we had a lot of companionship at the policy table, but also in terms of all sorts of things, and I learned a lot from her, both personally and professionally. A wonderful colleague, a really tenacious advocate, and again, we miss her today. And really a quality of care maven. And if you don't know the word maven in Yiddish, it means somebody who's an expert. So, and a cancer survivor. Okay, so anyway, I just want to, these were when I gave a talk about her and getting a similar award from ASCO earlier. These were some things that Fitzmullen said about her. And again, survivorship is a condition of its own. We need to change the system to achieve goals of survivorship. Getting doctors to change is like moving a battleship. Every survivor needs a survivorship care plan, and survivorship research should put more focus on delivery models and payment reform. So unfortunately, we're still doing that today. Okay, and the system falsely denies death, that we're all going to be living forever. So this was the model of what the trajectory of care was that was in the Institute of Medicine 2005 report on cancer survivorship, which Ellen co-led. And just to kind of point out on the left here, you have diagnosis and treatment. And this was actually showing this trajectory was kind of an aha moment for some of the oncologists on that committee who kind of didn't really understand that there was a period after cancer out there in the middle in yellow when people were living after treatment, and that this was a long period of time for many people. But if we look at this trajectory, and I really like to emphasize it today, probably 80% of the people we start treatment with today are going to be treated at least with the intent of cure, okay? There's some, say, with a very advanced pancreatic cancer or somebody who comes in with a very advanced brain tumor. We know from the very beginning they're going to be getting therapy, but it's going to be largely palliative. So from the very beginning, we need to think about all of those people that we are treating as potential survivors from the time of diagnosis. But here where I was, out in this yellow space, was the need for research. What happens after cancer treatments and or continue, and how can we improve the delivery, specifically here, of palliative care for survivors. And I'm going to define palliative in just a minute. So I want to talk about some definitions, which again may or may not be familiar to you. When we are thinking about the aftermath of a cancer treatment, we are usually thinking about two different kinds of things, although they're pretty much jumbled together in people's minds. There are long-term effects, which are really things that start with the treatment and never resolve. So think about the person who has very significant fatigue during their cancer treatment, and they just don't bounce back. And 2-3 years later, there's so much difficulty for them to resume their usual activities, and that's a persistent long-term effect. Cognitive changes that patients have, neuropathy, pain syndromes from their surgical procedures or radiation. All of those things are long-term effects of the treatment. And as Congresswoman Wasserman Schultz said, there are things that you just go on living with where your life is changed, and those are long-term effects. And it's true that some treatments are very minimal and don't cause problems. Some are very extensive and may or may not cause problems. And you can't really predict who's going to have one of these long-term problems, but everybody potentially is at risk. A late effect, on the other hand, is something that wasn't there. It just crops up later, many, many years later. It could be a second cancer. It could be heart failure. It could be some other complication that is rare, but is a result of the exposures that were given during treatment. So this terminology is complicated. Many times we all say it's a late effect, and we're really meaning long-term conditions as well. But it's really important to understand the etiology of when these are occurring, because that's very important for palliative care. Because if somebody hasn't had recovery from some of the symptoms that are occurring during treatment, or not even getting palliative symptom relief during treatment, they're going to be in trouble long term. And so that's important for us to recognize. So this is from the 2013 Institute of Medicine report, and just pointing out that care planning, palliative care, psychosocial support, prevention and management of long-term and late effects, and family caregiver support were things that we advocated from the time of diagnosis through treatment, through survivorship, through end of life, that these are part of the continuum of care, and we shouldn't wait to give those goodies to people when they're at the very end of life. And this is the other diagram that goes along from our report, is again, when you would say palliative care to someone and perhaps approach a patient about it, they would say, no, I'm not terminal, I'm not at the end here. But we really have to educate the professional community, the patient community, that in fact, palliative care is focused on symptoms when there's no other obvious cause. Now, if you have pain with urination and you have a bacterial infection and we treat it with antibiotics, that's fine. But if you're having pain from urination because you had radiation to your pelvis and your bladder is contracted and you have pain from that, there's nothing that we can do about that, and we need to find some kind of symptomatic approach. And so that's the difference about palliative care when we give it to people earlier in the continuum of cancer care. So somewhere along the line, this is back in 2011, I had been giving lots of talks after the 2005-2006 report, about survivorship care and how I did it and how I conceptualized it. And so finally, I gave a talk, I think in England, it was at an English National Cancer Research meeting, and somebody said, that's so wonderful, why don't you write it up? And there's this open access journal, and this long before we knew much about open access. So I wrote it up, and you can find it here. It's the 3 Ps of cancer survivorship. But this was kind of the way I had crystallized how we needed to deliver survivorship care in kind of a concise way. So I'm going to tell you about that. So this is the definition of palliative care from the dictionary. It's medical care or treatment that concentrates on reducing the severity of disease symptoms, particularly if there is not a curative medical treatment. Okay, now disease symptoms, you could also say treatment-related symptoms. And the goal is to prevent and relieve suffering and to improve quality of life for people facing complex illness. So we have a disease-free survivor, or even if we have somebody who's on active treatment and they have symptoms, we can't ignore them. We certainly don't try to ignore nausea and vomiting from chemotherapy treatment when we're giving it. So why should we be ignoring pain or fatigue or anxiety or insomnia or whatever that's going on with people getting treatment? So the focus in my palliative care history, when I used to work in a hospice palliative care setting, was I would say to the patient, tell me the 3 most important problems you're experiencing that I might be able to help you with. And I basically have used the very same strategy in survivors who fill out a questionnaire when they see me, to tell me what's really bothering you and how can I try to fix it, okay? So again, why is it important to understand the biology of these symptoms? I can tell you now, having focused for the last 20 years or more on both fatigue and cognitive function in cancer survivors, in particular breast cancer, patients are often dismissed by their doctors and saying, oh, everybody's tired after cancer treatment, or why are you worried about that? Or, so you're a little slow, who cares, Well, I forgot to pick up my kids at school after, at the end of the day, or I lost my keys or whatever, or I set the house on fire. I mean, a lot of things happen to people because they're cognitively impaired. So it is very important. And if you can, in fact, show that there's a biological underpinning, and this is me as a researcher, to whatever it is that the person's experiencing, your medical audience is going to say, aha, that's why this is happening, or we can explain it. And then for the patient, even if I can't fix their problem, if I can explain the biology and why they were singled out to get this problem or at higher risk to get this problem, there's a relief. It's like, oh, it's not all in my head. It's really a real problem. So we've done a lot of work looking at this, and again, understanding what's going on in terms of the biology, why some people have lingering effects and other people don't, and then this can lead to interventions, pharmacological or behavioral. We've done a lot in terms of cognitive therapy, cognitive interventions for both fatigue and yoga and mindfulness and a lot of things that are very effective for insomnia, fatigue, et cetera. And again, measuring biological outcomes in these individuals, showing that our interventions are actually moving the needle while they're getting better. And then there's a possibility that we can actually prevent other risk progression because we may do something to the biology of their symptoms. And again, this is not for you to look at in great detail, but there are a number of behavioral factors that may lead to the development of cancer, and they affect the mind-body axis, and that may also be part of what causes some people to get cancer and what the biology of the cancer may be afterwards. But I want to show you some more recent work that my colleagues and I have done to really kind of look at the fact that cancer and its therapy may expose people to sometimes what I think of as an atomic bomb, if you think about the radiation and other things that people get. And then you've got behavioral factors that the person, the host factors, they bring to the cancer experience. And this is at this center stage is what's going on in the cell, all the biological changes that are going on, not just in the cancer cell, but in the normal cells where there's exposure. And then you have some of the physical effects out at the end in terms of cognitive changes, functional changes, frailty. And again, one of the young prevention fellows at the NCI is interested in accelerated aging. And this is really one of the things that we think is happening to people who are living after cancer with these kinds of long-term effects. So, and again, what can we do about it? Well, here we've listed some behavioral interventions: stress reduction, sleep health, physical activity increasing, managing weight and energy balance, and tobacco and alcohol, actually reducing those and exposures that many cancer survivors still continue to drink and smoke, unfortunately. But that can then lead to biological changes. We've shown that for some of our integrative oncology interventions, and then we hope, obviously, reduce biological aging. And again, what are some of the things that we're talking about that we can do something about and try and attend to? Again, I haven't listed everything that survivors may have as long-term effects of their cancer treatment, but we can at least take those individual complaints that people have, the problems that are ongoing, prioritize them, and try to intervene on them as palliative interventions. Now, what do we need to do? Who are the people that we need to organize in our healthcare settings to do this? This is, again, just the list, but you can see we have to identify those specialists within our organization who will then become specifically interested. So I have a wonderful cardio-oncologist who I nurtured, and he's now an expert and has an international cardio-oncology center as a result, like 10 years later, because I was referring him patients. He was very excited, and there are many, many new drugs that we have that are cardiotoxic, some of the targeted therapies. So he sees people acutely, but he also sees the long-term survivors. And just an example, so you have to cultivate these specialists to be interested in the palliative care of cancer patients and survivors. And again, just to reiterate, palliative care, very important at the end of life. We need to make sure that that's done, but we need to integrate it along the whole continuum of care for people who have been diagnosed with cancer. So prevention, and Congresswoman Wasserman Schultz talked about this. Prevention is very important in terms of preventing the initial episode of cancer, but we know that about 15% of the new cancer diagnoses each year are in people who have had cancer before. So secondary prevention of cancer in cancer survivors is absolutely critical. And again, looking at early detection, again, if patients kind of drop out of care, as she mentioned, she now really pays a lot of attention to this. She has a genetic predisposition. But all of these other things, cataracts, osteoporosis, cardiac disease, chemo prevention, again, young women who've had chest radiation for their cancer, we can give them the drug tamoxifen for chemo prevention to decrease the risk of breast cancer. So that's important. Genetic counseling for hereditary cancers, again, if you have the genetic test, you can then screen for those other secondary cancers that you might get in the future if you're at high risk for, or do prevention for. So very important to make sure that our survivors know about that. And then lifestyle modifications that can be important in terms of reducing the risk of a second cancer. And then health promotion. This is absolutely critical. We need to reduce the risk of chronic comorbid conditions, which are part of that accelerated aging process, to have accelerated cardiac disease, lung disease, kidney disease, whatever, depending on what the exposure is. To the extent you are aware that this could happen, like the young sarcoma patient that you saw in the video, you can then monitor and intervene along the way for this. And it's very important in terms of behavioral interventions that may also reduce those ongoing risks. So this is when I give a talk on accelerated aging, this is kind of what I like to show. Down at the bottom, you see this dashed line, frailty. Frailty is a term that the geriatricians use about people at the end of their life really becoming less physically active, having more fatigue, weakened in their function. And the geriatricians or the gerontology community would like to all have us just have frailty for 1 month and then die. But it doesn't happen. It's usually, it's usually 3 to 6 years. And if you've watched an older relative go through this, it's a long time experience for them and they lose ground. So unfortunately, we know from childhood cancer survivors that this is a problem in terms of the health span being limited in survivors. And I'll just do my animation here. So multimodal cancer treatment, while wonderful in curing people, may in fact move them down to this other curve of a reduced lifespan or health span, getting to frailty at an earlier time point. And really, this is related to the accumulation of increased comorbid conditions. And again, how can we alleviate this? Well, exercise, diet, prevention, and surveillance can be things that we can do to improve that health span and reduce the time that they may have frailty. So how to deliver this? Again, it hasn't been solved yet. We have to really figure out how to do this. We still need new models of healthcare delivery for survivors. I was so glad to hear about the legislation that's attempted now, and it's fantastic to see this happen. One size will not fit all. We have many communities that have poor access, rural communities, inner city communities where access may not be good. So we need to make sure that everybody has a chance at this. And again, what's right at UCLA may not work somewhere else. You've seen one cancer center, you've seen one cancer center. And again, we need to do those treatment plans right from the beginning. So we are making decisions about care that may give patients the best long-term outcome as survivors, whether they're going to be living with cancer on an ongoing basis or whether they're going to be disease-free for a period of time. And we need to educate them about what they can do to help in their recovery, and that's really what the care plan is about. So I wanted to just show the late Jessie Grimman, who some of you know, who unfortunately, as a result of radiation therapy for Hodgkin's disease, had multiple other cancers. And she said here in this quote, "Those of us with multiple chronic conditions may consult many physicians in the course of a year. Last year I saw 11. Not one of my doctors has ever communicated directly with another, despite the fact that some of them work in the same health system and have offices in the same building. I am the sole arbiter of who gets what information and in what format and when." So again, this should not be the case. I think the electronic health record has really helped a lot in this regard, even though the notes are not always great. We're sometimes all in the same system now, and we can even look across the country and see the notes of other doctors. But again, this is a big issue for people living long after cancer who've accumulated these chronic conditions. So I just want to give an example. So if we're worried about congestive heart failure, which is a weakened heart as a result of the radiation or chemotherapy or other drugs somebody has received, we have to think about it really right from the get-go. We need to know how the patient's functioning in terms of their heart function and whether they're going to be at high risk for some complication. So at diagnosis, we need to figure out who those high-risk patients are. And again, most cancers occur in people over 65, so a lot of them already have underlying heart disease as an example. We need to change the treatment, or we need to tailor the treatment to that risk factor. And I could have put up fertility, I could have put up neuropathy, I could have put up any kind of target symptom here if you wanted, but I chose this one. And then again, once the person has that condition, we need to get on it. We need to treat them. And we may even be able to do some preventive interventions in somebody who's already lost some cardiac function as part of the treatment. And so this issue of really doing things right from the beginning, palliative care, and thinking about symptoms that may occur over time is very important for risk assessment and intervention. Developing safer therapies, and this is really important for us. We don't want to give everybody neuropathy if we can avoid it. Will we have some drugs for myeloma and for colon cancer and for breast cancer that don't have neuropathy in the future? And again, once somebody has this established, we need to manage it. And we need to think about the medical outcomes and quality of life for these individuals to maximize them as part of our palliative interventions. And this is really how my 3 Ps come together in terms of survivor healthcare delivery, where we're focusing on palliation, prevention, and health promotion. So in conclusion here, I think survivorship care and palliative care go hand in hand with each other. It should be something that we could advocate for. Certainly if we wanted to talk about anything in the bill she's putting forward, getting someone focused on symptom management and prevention of symptoms, that's pretty easy if you could give them a list of all the kinds of common symptoms that patients have after treatment. And again, in closing, with attention to survivorship needs, there can still be a good life after cancer. So thank you very much. Do you want me to take some questions? Okay, great. So I'm open to anything. I made it sound like it's a piece of cake, but it isn't.
I am a survivor, a volunteer for NCCS, and as a long-term survivor, what would you say the most important things are that I can take into my own hands to ensure a long, healthy survivorship?
So I think you really need to know what treatments you had, and again, for some treatments, we have pretty good knowledge about what that exposure. So let me kind of let you think about how I think about it. We often, as an oncology community, kind of focus on the tumor, its molecular characteristics, what kind of treatments we should define based on how big the tumor was, all those other features, and what's available. And we don't think about the person, and the tumor arose in a human being who had a certain environment. Maybe they were drinking, maybe they were smoking, maybe they were overweight, just a whole bunch of other things. Maybe they have a genetic predisposition. So those are what I call host factors. And so the tumor occurs in a person. So as a survivor, you need to know about what you got and what your exposures are, and you need to hopefully learn from the literature or finding knowledgeable resources if there's any interaction between something special about you and the exposure you had and what might be consequences of that exposure. And for some people, it could be minimal. I mean, you have a melanoma that's, very thin and it's removed and nothing to worry about. You just need to worry about whether you're going to get another melanoma in the future because of that predisposition. If you had breast cancer, you have to worry about if you had a lumpectomy and radiation, you could get another cancer in that breast or the other breast. You certainly could have another recurrence. But you need to understand what treatments you had and what do we know about the long-term effects. Unfortunately, for new drugs, we know very little. So I happen to work in the cooperative trials group, so I'm very lucky. I have trials now where I've had patients who've been on immunotherapy, and I'm going to have quality of life data and fatigue and other data available for them, so I'll have more knowledge. But somebody getting immunotherapy today or some of these other targeted therapies for lung cancer, we don't know anything yet. So we don't know anything beyond the first few years. And the medical literature that gets reported is very superficial in terms of capturing these data. So there's a paucity of information. But for diseases where the treatment hasn't changed, there's stuff in the literature that someone could help you find. So.
Thank you. You're amazing, and for everything you do for patients and families. So question, excuse me, I had cancer, like a fun, easy cancer. Caregiver, like surgery, no treatment is what I mean. My caregiver to my mom, but curious about like reimbursement and the policy solutions to get more access to palliative care. I mean, I was aggressive for my mom to have palliative care consults, but it's obviously not standard of care. But are there policy levers that we should be looking at to create more access.
Yeah, the National Palliative Care Professional Organization is very interested in doing a lot of this. Our big problem is there are relatively few palliative care certified physicians in the U.S. It's a little like geriatrics. There's not very many. And so the oncology community has kind of said, well, we do palliative care. I mean, you saw I did palliative care for a long time before there was ever a specialty. But there has been this effort now to marry joint care, particularly in people on that more serious trajectory, if you will, where we know right from the very beginning people with high-risk lung cancer, other GI malignancies that may be higher risk to do that. And so in tertiary centers that may be available, but there are a lot of community centers that are on this. So asking for it, I think, is the first step. Because even within a medical center, there may be some physicians who are in tune with that and others not. And doctors are very interesting. They don't know everything, but if a patient asks them about it, they're going to go figure it out and ask about it. So asking about it, but certainly at the policy setting level with NCCS and whatever you're doing, again, even if the legislation gets, parceled out, getting palliative care from the very beginning can be very helpful during treatment. Now we're actually showing a lot of physical activity interventions during treatment, get people to complete their treatment better and end up better at the end of treatment. So again, those are strategies that need to be used, and use the literature. There is a very good oncology community that's interested in these things, so there are emerging data. But I think advocating through these kinds of networks can be very important.
Thank you so much for all you do. So I'm actually the child of a 3-time cancer survivor. And so when I was looking at your slide, it made me think about this last time. My dad is the one who's he had prostate cancer, he had colon cancer at 45, prostate cancer at 60, and then this year had colon cancer again. And when I was looking at your list, it made me think, as a caregiver, some of the things, what do we have to look for, and how do we help navigate, particularly older parents, through some of these processes?
Yeah, I think the issue is not to ignore the problems. I think there's this tendency, there's always been this tendency, you should be thankful to be alive. We did a good job, or, that's the doctor. I mean, it used to be with the radical mastectomies that women had, the doctor would say, we got it all. Of course, then the patient had a recurrence a few years later because we know about the biology of cancer. It's not just localized. And so has your dad had genetic testing? He needs to get it because you could be the recipient of important information. Okay, young age for colon cancer, 45 is very young. He needs to be tested, okay? So that's very important, and maybe that's knowledge you didn't have, but again, as a survivor and somebody who's had 3 cancers or a repeated colon cancer, that's very important. So, not ignoring these things, because again, of the whole accelerated aging, people are getting older anyway and acquiring these chronic problems, but the cancer treatments can make it worse. So not ignoring symptoms that people may have, even though it may be hard to find somebody who will listen to you.
Dr. Ganz, we love and admire all the work that you do.
Yes, my good friend Julia.
Needless to say. So I wanted to respond. That was such a wonderful comment about caregivers who, of course, are traveling along this journey also. So thinking about how do we better engage them in this? What do we need to be doing for caregivers? And then the second question for you, Dr. Ganz, because I know you know all about this. We've heard a lot about the medical, the fatigue, the sexual dysfunction, the pain syndromes, et cetera. But talk to us about where we're going with the emotional evaluation. So anxiety, depression, stress, PTSD, post-traumatic stress disorder, for those who don't like acronyms. Have we made any advances, and how are we going to do better with that along the trajectory?
Yeah. So this is my latest. I told you about the fatigue and the cognitive. Well, I'm on my high horse about depression. And I just completed a study with my colleagues looking at younger women, survivors of breast cancer, who were less than 50 at the time of diagnosis, and doing interventions to address depression. And of course, we did the interventions, but we drew blood and looked at inflammation because, again, we want to show that whatever we're doing to help with something is also moving the needle on the biology, because that's where we're going to get people's attention. Because, again, just saying somebody's feeling better is not enough for a lot of people when it should be, okay? But how do I convince other scientists that interventions not only are needed, but very effective? And so in the case of this study, the women were 2.5 years out. They were about 46 years of age. They were treated in the vicinity of Dana-Farber Cancer Institute, Johns Hopkins, and UCLA. So all places where there were very rich resources for integrative activities, psychological therapy approaches, et cetera, et cetera. Yet when we actually looked and asked, are you on any medications? Have you received any help? They had high levels, very substantial high levels of depression. We screened for some level coming into the study. Most of them had not gotten anything. So this is a huge gap in service delivery. And Congressman Wasserman Schultz kind of derided the U.S. Preventive Services Task Force, but they do have a B recommendation for depression screening for everyone who comes to a primary care physician. And we have guidelines from the Commission on Cancer of depression or anxiety screening in cancer survivors, cancer patients. It's not being done. And it's really one of these terrible existing problems that patients have that go unaddressed. And when I said knowing the host characteristics about who that person is, past history of depression, nobody ever asks that, okay? And if you see somebody who has a past history of depression, they're at high risk to get another episode of depression. But that's just a simple question you can ask. So the healthcare system is very weak in addressing these problems, and they are addressable with interventions. We showed that our mindfulness intervention 6-week program in these young women not only reduced depression significantly, but it also improved insomnia, fatigue, and hot flashes, okay? So very inexpensive. 2 hours a week for 6 weeks, okay? We're now trying to move it into a larger scale trial across the country. But the bottom line is there is help. These people are in pain, they're suffering, and the family thinks everything's over with, you don't need to worry about it, and they are suffering in silence. So I don't know if I answered your question, but this is a terribly important need and needs to be on the agenda. And as I said, everything we are trying to do to show there's a biological benefit to helping, and some of the work we're showing there's greater work productivity, so young women in the workforce, maybe taking care of their children, doing all sorts of other things, need to recover from their mental as well as their physical complications from cancer treatment. So, is that enough from you? Okay, thank you.